Good morning, everyone. Thanks for joining us today. I'm Stephanie Maselli, Media Officer with the National Academies of Sciences, Engineering, and Medicine. Thank you for joining us for a public briefing for the recently released report, Integrating Social Care into the Delivery of Healthcare, Moving Upstream to Improve the Nation's Health. A free downloadable copy of the report and related resources are available at nationalacademies.org/socialcare, and the slides and recording of this webinar will be available there within the next week as well. We are also using the hashtag #SocialCare if you wish to follow the conversation on Twitter. And for those of you who are not familiar with the National Academies of Sciences, Engineering, and Medicine, we are private, nonprofit institutions that provide independent, objective analysis and advice to the U.S. to solve complex problems and inform public policy decisions related to science, technology, and medicine. For each requested study, panel members are chosen for their expertise and experience, and they serve pro bono to carry out the study's statement of task. The reports that result from the study represent the consensus view of the committee, and they must undergo external peer review before they are released, as did this report. I have with me several members of the committee to discuss the report, but before I introduce them, I just want to go over a few housekeeping reminders. This webinar is scheduled to last 1 hour. We will start off with a presentation summarizing the report by the committee members, and then we'll open it up to any audience questions. You can simply click the Q&A button on the bottom of your screen to submit a question. And if you have any technical issues during the webinar, please contact Zoom technical support. That number is 1-888-799-9666 and select option 2. Now I'd like to introduce the members of the committee who wrote the report who are here with us today. We have our chair, Kirsten Bibbins-Domingo, who is a general internist and vice dean for population health and health equity at the University of California, San Francisco School of Medicine. We have Karen DeSalvo, professor of internal medicine and population health at the University of Texas at Austin, Dell Medical School. We have Chris Esguerra, senior medical director, Blue Shield of California, and Robin Golden, Associate Vice President of Population Health and Aging at Rush University Medical Center. And with that, I'd like to turn it over to Dr. Bibbins-Domingo to get the presentation started.
Thank you very much for joining us today and for your interest in this report. I'm going to begin this report by describing the task that this committee was charged with addressing. This is a committee of the National Academies and was tasked with examining the potential for integrating services that address social needs and the social determinants of health into the delivery of health care in order to achieve better health outcomes and to address major challenges facing the U.S. healthcare system. Next slide, please. We had a broad coalition of sponsors that helped to convene this committee, and I think this broad coalition of 17 organizations who sponsored the work of this committee reflects the high level of interest in this particular topic at this time, as well as the multiple stakeholders that are involved in trying to do this work better. We convened an expert committee with expertise in the healthcare setting, in social work, nursing, and in public health, people who came from a variety of different sectors, including academia, the private sector, and government organizations. And again, this is a body of work that requires expertise in many different areas. Next slide, please. Our approach was to first collect information. We started with the peer-reviewed literature and did a comprehensive review of this literature. We also looked at the gray literature and websites that are highlighting work in this area. This is an area where there is a lot of ongoing work, and so we tried to be expansive in the types of sources of information. We also held several public meetings and invited presentations from groups and organizations who are working to do this well. We reviewed and analyzed the evidence base and used it to develop findings and recommendations. These were summarized in a draft report. The draft report went out for external review, and then we finalized a report based on the comments from the reviewers as well as the input from the rest of this committee, and this report reflects the consensus of the committee that was convened to do this work. Next slide, please. Here's the case for integrating social care into health care delivery. We know that social factors influence health. These include things like housing, healthy food, reliable transportation, as well as many other things. The healthcare sector has traditionally focused on providing medical interventions to prevent and treat disease, and not necessarily focused on the upstream factors that we know are important contributors. Addressing social factors within the context of healthcare delivery is important for high quality and high value healthcare. Next slide. Why is this report important now? We have many movements in the healthcare sector that are moving us to more value-based ways of assessing and financing and evaluating the quality of healthcare that we deliver. Certainly social factors in the context of healthcare, when they're addressed there, can be consistent with this move. There's a growing body of evidence on how to do this well. And there's active interest from multiple sectors who are trying to do this work. And because of the great variety of activities in this area, the committee felt it was important to develop a taxonomy and a framework to organize discussions around these activities so that we understand how to develop, implement, and test models for doing this effectively, as well as discussions that might inform policymakers on the types of changes that might need to take place to do this in a better way. Next slide. Health and health equity were at the core of all of our discussions and our recommendations. Everyone's health is affected by their social context, and everyone may experience social needs at some point in their lives. Following hospitalization for an acute illness, as we age, we may have particular social needs. For some individuals and communities, these needs are multiple, they're ongoing, and they're faced without the resources to address these needs. And this leads and directly contributes to disparities in health. So addressing social needs is something that may be important for all of us, but is particularly important for addressing health disparities. Equity was also a theme that we kept at the forefront in all of our recommendations so that we can ensure that the strategies that we develop in order to integrate social care into the delivery of health care don't inadvertently end up worsening outcomes for individuals and communities at greatest need. Next slide, please. The committee developed a framework of we call 5 A's to facilitate integration of social care into the delivery of health care. These are 5 complementary sets of activities that happen within the healthcare sector that might help to address social needs. At its core is awareness about the importance of social determinants of health. Awareness in general for all members of a healthcare team, awareness of how a social factor may influence the health of an individual patient, and awareness for how the healthcare delivery sector might play a role in addressing social needs within a community. The adjustment and assistance activities are really focused on individuals in the context of receiving health care. Adjustment means that the healthcare sector can adjust the way in which health care is delivered so that social needs of a given patient might be minimized within the context of how they receive care. Assistance is directly addressing a particular need for a given patient. The alignment and advocacy activities really focus on how the healthcare sector can align with community organizations and invest in community-based strategies to address social needs. The advocacy speaks to organizing and engaging with cross-sector coalitions to advocate for policy changes that directly address social needs within a community. Many institutions have been adopting anchor strategies that are consistent with both of these, that recognize and leverage the social, economic, and political clout that healthcare organizations have in their communities to address the social needs in those communities. Next slide, please. Here's an example of how the 5 A's might be applied to transportation. Awareness, understanding how patients that might be seen in a clinical setting have access to transportation and whether that affects how healthcare is delivered for those patients. Adjustment might mean minimizing in-person visits that might be necessary for managing an ongoing chronic condition and converting some of those to telehealth appointments. This might be particularly important for patients who are traveling long distances or in rural settings. Directly providing assistance in the form of travel vouchers to patients so that they can make them to their healthcare appointments. In the alignment and advocacy area, this might include investing in community ride-sharing programs or working together to promote policies that fundamentally change the transportation infrastructure within a community. Next slide. In all of these, we identified 3 key necessities that are important for successful integration of social care into healthcare delivery: an appropriately staffed and trained workforce, information technology innovation, and new financing models. And I'm going to first review the findings, a summary of the findings in each of these areas, and then lead right into our recommendations. Next slide. So within workforce, all members of a healthcare team should be aware of social factors and their influence of health. But there are experts in social and addressing these social needs, and these experts are critical to interprofessional teams. Working together in teams effectively requires clarity about the roles of individual team members, as well as building skills about how teams can work together effectively. There are several federal, state, and institutional barriers to workforce. These include limiting the scope of practice of social workers and other social care workers in caring for patients so that they're not used to their fullest extent, as well as limiting reimbursement for activities delivered by social care workers within the context of healthcare delivery. Next slide, please. In the area of data and digital tools, advances in technology have the potential to greatly facilitate integration of the healthcare sector and the social care sector. There are many local efforts ongoing to share healthcare and social care information, but these are not supported by a national strategy or coupled with resources. Key to this is interoperability and data sharing, and this is hampered by the lack of infrastructure, lack of data standards, and lack of modern technology architecture that would allow for sharing between social care organizations and social care organizations with the healthcare setting. Next slide, please. Within financing, the legal definition of healthcare does not allow for the inclusion of social care as a part of healthcare, and that limits reimbursement for many of these types of activities. The methods of how we pay for healthcare can both incentivize or actively disincentivize the inclusion of social care in healthcare delivery. Value-based payment structures have the capacity to align incentives for the provision of social care. And importantly, when we're talking about connecting healthcare and social care sector, is recognizing that the administrative capacity of many social care providers and organizations is limited compared with the healthcare sector. Next slide. So the committee defined 5 goals for effective integration, and within these goals, we grouped several recommendations. In order to do this effectively, healthcare delivery needs to be designed with the goal of addressing social care into the context of healthcare delivery. The workforce needs to be supported that would allow for this effective integration. A digital infrastructure needs to be developed that is interoperable between healthcare and social care organizations. We need to have financing models that support this type of integration, and we need to fund, conduct, and translate research and evaluation on work that's already being done so that we know and understand best practices in this area. Next slide. So within our first goal, this is a set of recommendations that are addressed to healthcare organizations. These organizations should design and implement integrated care systems, and to do this by engaging a wide variety of stakeholders, the many perspectives that need to be at the table in order to do this effectively. Healthcare organizations should support the development of infrastructure components needed to meet the goals of integration. And I will point out that this report has a really outstanding chapter on the many implementation strategies and some of the opportunities and challenges in integration, in the implementation of these types of models. And so infrastructure is needed to support successful integration. The healthcare organizations should establish linkages and active communication pathways between healthcare and social service providers, and to support these types of relationships with referral and financing relationships when feasible. Next slide, please. The second goal is related to workforce. We identified a scope of practice as really important for developing a workforce that can meet the needs in this area. And so those bodies that are responsible for developing, expanding, and standardizing the scope of practice for social workers and other social care workforce are really critically important for ensuring that, that these scopes are standardized and ideally expanded. Social workers and other social care workers should be considered providers who are eligible for reimbursement by payers. Next slide. Training is important for all health professionals, and training specifically on social factors and how they affect health, both in the formal curriculum as health professionals start in their training, as well as ongoing continuing education. Such training should also include how to work in interprofessional teams and how to do this in a variety of settings. One way that this could be done well is to engage social workers and other social care providers in instructional roles in order to model their participation on interprofessional teams, and how to do the types of awareness and referral in the context of healthcare delivery. And schools of social work should use, as well as other health professional schools, should use competency-based curricula on social care. Next slide. The federal government and the private sector should build internal capacity for social care organizations and consumers to interact with each other and with the healthcare system. These groups should provide resources to create digital systems to facilitate eligibility and continuous enrollment, and provide support for deploying interoperable platforms for communities. Equity is particularly important in all of these recommendations, and within this area, to ensure that advanced technological and digital advances are designed to address all communities that might benefit, and in particular to help to ensure that as data sharing happens, that it doesn't inadvertently lead to more adverse outcomes and processes for those individuals and communities of greatest need. Next slide. Within financing, we have a set of recommendations addressed to the Center for Medicare and Medicaid Services, who should clearly define what aspects of social care are considered covered services under Medicaid, to approve Medicaid waivers that support social care and include sustainable financing when these interventions are found to be effective. within Medicare to consider additional Medicare reforms to broaden coverage rules and to coordinate with states for coverage and benefits administrations for those dually eligible populations. Next slide. States should communicate to health plans and the healthcare and social care providers about the social care activities that can be covered by Medicaid. They should pursue policies of continuous program eligibility and pursue opportunities to align hospital licensing and reporting requirements to ensure consistent obligations for health systems with respect to their community benefits, as these might be used to invest in provisions of social care within the community. Next slide. The last goal relates to ongoing research and evaluation, and the recommendations here include continuing to encourage demonstration projects and other type of research with a variety of different study designs, to develop a clearinghouse for promising practices so that we can learn from others on what's being done in this field, to develop common core measures to allow for comparisons across projects, as well as integration of validated instruments when they become available, and to use research on effective demonstration to inform healthcare reforms. Next slide. That's the end of my formal remarks. I'd like to thank you for your interest in this report and in this important area of integrating social care into the delivery of health care in a way that improves health for all. With that, I'm happy to take questions.
Excellent, thank you. As we wait for audience questions to roll in, we thought we'd kick off the conversation and ask, can you give examples of actions that can be implemented right now?
Sure. We have a lot of recommendations in the report, but within our 5 framework, we have 5 sets of things that people could do now in order to further these activities. The first relates to the 5 A's. These define a broad set of activities that the healthcare sector could engage in to integrate social care. The committee felt that this was not a one-size-fits-all strategy, so I would encourage organizations to review the 5 A's, review the activities they may already be engaged in now, and identify strategies to amplify and encourage and continue to develop within activities that they might already be engaged in now. Secondly, within the context of training, everyone needs to be trained to have both formal and ongoing training in how to deliver social care in the context of health care, in the importance of social determinants of health. This relates to formal curriculum for how we teach in medical schools, in nursing schools, and training that includes instruction with those experts in the delivery of social care, like the social workers. The third recommendation would be all of this report is about partnership between the health sector and the social sector. And in the data sphere, it's important for these sectors to begin discussing strategies for sharing data in a way that enhances referral, but also in a safe way that protects the privacy and rights of the consumer. In the area of policy, while we have lots of recommendations about how policies should be changed, the reality is that many of the activities we're talking about are currently allowable within our current policy framework. So we would encourage health delivery systems and their partners to continue to move forward in these areas and not wait for policy change, but to do this with their experts in legislation to understand how to continue to advocate as one comes up against a barrier to doing this effectively. And then finally, while the science is strong in this area, it could be strengthened, and so we need more research to continue to understand how to do this in the best way possible.
Next question, are state and local public health agencies included in the healthcare organizations' related goals and recommendations? And more broadly, what is the role of government entities in the recommended digital platforms?
Great. I'm going to turn this over to my colleagues on the committee.
Great. Thank you for the question. Let me start with the question about public health. This is Karen DeSalvo. I'm professor of medicine and population health at the Dell Medical School, and relevant for the second part of the question, also the previous national coordinator for health information technology. Public health would be considered part of the set of partnerships that we would want to see included, particularly in work around in the A's that describe alignment and advocacy. And in the chapter on data and digital, for example, we provide two examples in that space that talk about the role of public health as a partner. We use the model of Route 66, which is a public-private partnership in Oklahoma that is a partnership between the healthcare system and local public health to provide coordination and resources of services, in addition to some digital infrastructure to support referral coordination. And we also use the example of Louisville Air, which was a model of the Louisville local government, including the health department, working with technology folks as well as the healthcare sector to not only improve the health of individuals, but to improve the health of communities. So the charge of the report was to focus on what healthcare systems should do, but one of the main themes of the report is that they should do this work in partnership with others, including with public health and the social care sector. We have related to the question on roles and responsibilities around the recommendations on building out the technology and digital infrastructure. This clearly seems to be also an area for public-private partnership and action. And though we do call out a number of areas where within current authority or resources, HHS, and in many cases, the Office of National Coordinator could take action to drive the development of open standards that will allow data sharing between the health and social care sectors with appropriate privacy and consent. There's an important role for the private sector to play also as they build out new technology to agree to do that technology in a way that allows for open standards and for consumers to be a part of information sharing so that they can be more engaged in their care. So the set of recommendations call out that there are actions that could be taken now by the public and private sector to create not only an interoperable system, but to strengthen the digital infrastructure on the social care side.
Thank you. There is a growing focus on incorporating bottom-up co-design, incorporating people and patients and their direct caregivers in addressing social needs and social determinants. How did you incorporate their voices into your deliberations?
This is Chris Esguerra with Blue Shield of California. One of the things that in our deliberations and really thinking about incorporating social needs care into the delivery of healthcare is centering the individual that's actually receiving the services and how we identify. And as we were going through, in particular in the workforce chapter and identifying who can provide, we also identify their informal caregivers as part of that. And when we talk about the interprofessional teamwork, we also have the broader definition of team to really incorporate not just the professionals as identified, but really the natural supports for that individual, and in really taking into account a more holistic view of that individual's life as it affects their health and well-being. And getting into then, how does that filter through the rest of the overall system and in ways in which we protect the data, we protect privacy, allow for that coordination, as well as allow for the appropriate financing for these particular issues.
Next question is, what are some policy solutions to the reimbursement and workforce challenges you described?
This is Robin Golden. There are many at different levels, but some of what we highlighted in the report has to do with obstacles based on who we consider to be healthcare professionals. And sometimes some of the social care workforce that we talked about, social workers, community health workers, gerontologists, even medical legal partnerships, are not considered within the healthcare professional realm, unfortunately, to be reimbursed by our majority of a current fee-for-service system that we're working with in this country. We hope that'll change with value-based, but until then, I think we should relook at who we're calling healthcare professionals, because that's the only way we're going to really be able to bridge the divide between the social care sector and the healthcare sector in terms of working across the sector and caring for the people we're wanting to serve. People don't live in hospitals, they live in communities, so it's really critical that we figure out a payment structure that incorporates all of that.
Yeah, this is Chris Esguerra. To add to that, the key piece of broadening the definition of who is able to provide healthcare services in this new ecosystem, underlying that is as well making sure those definitions follow the financial framework. And understanding that we currently, for the most part, still live in a fee-for-service world, expanding that capability and that understanding of who is a healthcare provider allows us then to move into the value-based system and understanding who truly is part of that team.
Was there a recommendation to create standard interoperable social need referrals using direct connect technologies that don't require social needs software platforms or other add-ons? And would other government agencies be prompted to adopt those standard interfaces?
This is Karen DeSalvo again. Thank you for the question. We did not go so deep as to make particular recommendations about the types of technology standards that should be used, though the report does encourage the use of modern standards that would create a more open architecture. So for my tech folks on the phone, ones that can create APIs or doorways to the data, so less of a emphasis on direct connection, though that is a pathway that some systems may choose, but one that can create more of a long-term or longitudinal health record for an individual that would allow data to be input into that record, not just from the electronic health record, but from consumer reported outcomes or other important sources of data, say from housing agencies or food agencies, so that there's a new shared record about health and not just health care. And that implies that there would be some use of open standards for these APIs or doorways to the data that would be able to connect with the standards that are typically used in healthcare, whether those are HL7 or others, and those that would be more typically used in the social care infrastructure like NEAM. And that's the direction that the committee wanted to see the ecosystem go, so that it was a more open, interoperable system. And we call out some particular actors in the recommendations at HHS and in the government who have a role to play. But your point also raises the important concept that there will be a need for interagency work across government to see that data and standards from important sources that talk about other social needs like housing, transportation, and education are appropriately available and able to inform the care plan and action to see that people have access to the services they need.
Thank you. Will you provide specific examples of how your recommendations can potentially be implemented in a hospital setting? For example, would designing a survey instrument be useful to capture data from inpatients and outpatients about their social needs?
So thank you for that question. We have several types of recommendations in the report for how different healthcare organizations and settings have been trying to integrate this most effectively. We have a really nice chapter on the specific implementation challenges, what to do, what not to do, that goes through a series of questions that I would really urge you to read in this report. when it comes to developing instruments that you might use more routinely across groups, I think there is a lot of interest right now in developing tools for social screening that might be used in a variety of different settings. Some organizations are even using these more routinely, some using them in more targeted ways. I think this is an area where there need to be more validated instruments, and that is the recommendation of the committee, is that there needs to be general awareness of how to do this, awareness of the tools that are being developed, and that if one is going to do something in your particular setting, it sounds like in the context of the hospitalization or linking the hospitalization to the outpatient, that there are validated tools that might be used. So I'd urge you to look at both, I don't know the specifics for your case, but I'd urge you to think about what tools are already out there and might have been studied to understand how to develop them for your context, and also to look at our chapter on implementation, because it has a lot of really good on-the-ground details on how one might do this in real life.
Thank you. This is a two-part question. Did the topic of unintended consequences when identifying social risks come up in your findings or recommendations? And as an example, what safeguards can be put in place to make sure that once disparities are identified, this information is not used to further marginalize or discriminate against certain populations?
This is Karen DeSalvo. Thank you so much for that question. And as Kirsten laid out in the beginning of her remarks, the notion of health equity, not only leveraging social care as an opportunity to eliminate disparities, but also attention to aggravation of disparities, was a theme throughout our deliberations. And I believe you'll find a theme throughout the report. We described in the report potential unintended consequences in a number of areas, including the concern that medicine might try to take all this on its own and not partner with others, particularly those who have deeper historical expertise in social care, like those in the social work field. And so this theme of teamwork and partnership is a pathway for healthcare to strengthen not only its own role in integrating social care, but for there to be strengthening of the partnership, so that this isn't a medical solution or medicalization of the social determinants, but instead a pathway to strengthening local and national partnerships for action. In the area of digital and technology, this was a particular point of concern, given that there are already disparities in access, not only to telecom, whether that's cellular access or broadband, so some assumptions about how people will use digital referral platforms or eligibility and enrollment platforms that we describe and recommend in the report may be exacerbated for rural communities and others who don't have access, but also that some of the analytic tools that are increasingly being deployed around predicting who's at social risk based upon personal or zip code characteristics based upon where they live may make assumptions that are wrong and put people, harm those that we most want to help. They may, by labeling or categorizing folks. And so attention to understanding how those models are built, and that they're built with not just some populations where that may skew the results and create some labels or misinformation. So it is an important part of the report. We would expect that there's attention to that in a number of ways, but also that those who are involved, I'll just specifically talk about the data and digital part, are building those tools and technologies with equity in mind and paying attention to potential unintended consequences and harm.
It's Robin Golden. On the specifics with that, we wanted to make sure that if screening does occur or questions get integrated somewhere, that it's not done just with identifying an issue and sending a person on their way with a referral. it really should be, and hopefully our best practices that are listed, we talk about it's within the context of an ongoing relationship, because if people have that degree of needs, they most often need ongoing social care resources. So it's important to think about and look at some of the care management models we talked about in here, and in no way we talked a lot about we never wanted to increase any shaming or blaming that could happen as a result of these kinds of cold screenings. We were thinking of a much more warm, ongoing approach.
This is Chris Esguerra, and to add to that, so kind of going back to the 5 A's in terms of our activities and the framework, it's really this idea of awareness. The examples we gave was the awareness of that individual treatment setting, yet we're also thinking about awareness from a systems perspective. And the awareness then of potential unintended consequences, how to build a trust framework amongst partners, but also with the community, with the individuals, is really peppered chapter, and a deep dive into that in chapter 2, and really thinking about this from a health equity perspective helps us guard against that. And in the implementation chapter, really frames a decent number of questions that allows an organization or an overall strategy to safeguard and then be attentive to those particular issues.
This is Kirsten Bibbins-Domingo. One of the things I want to underscore, and I thank you for that question, it's really important. We have a report that has recommendations across many different domains, and I think what's important is to really understand that to do this effectively requires attention to all of these domains. And I think that becomes particularly important in the data piece. So we have not made a recommendation in this report for universal screening, for collecting lots of information. This is a report that's really about partnerships and building relationships between the sectors in order to do this well, and the digital piece becomes just one way to do that effectively. There's concern with the data because the data oftentimes moves very quickly, and our ability to identify individuals who might have high social needs without this type of partnership and relationship in order to use that to address those needs, I think is by itself potentially problematic, and particularly when coupled with the risk that then these data are used in a way that might be disadvantageous or ultimately harm individuals and communities that a fully integrated system might have the most potential to benefit.
Thank you. When you say social work education should be competency-based, do you mean the competencies that the Council on Social Work Education requires, or do you mean developing competencies beyond that? Is there an example in the report about how you envision this education unfolding?
Sure, it's Robin Golden. Great question. No one was criticizing the competencies in anybody's area of focus, medicine, nursing, et cetera, in terms of social work. We were just talking about how to incorporate social care aspects of the work into existing curricula. In terms of social work, what we talked about distinctively was that social workers both need to learn and hear about the broad aspect of their roles, and particularly how they can best interface with the healthcare sector. Learning the language, learning the cultural aspects are critical in order to bridge what is often a divide. So in that regard, I think it's helpful to think about adding those competencies in terms of social work. We also talked about social work then taking a leadership role in many of the competency changes or training that goes on in other schools in order to incorporate their expertise in developing the social care aspects of medicine, nursing, and all the other professions.
Thank you. Case managers from commercial payers are starting to address the social determinants of health. Does the report have a call to action for commercial payers to define, expand, or standardize benefits?
This is Chris Esguerra. Why, yes, we do. So the whole idea here is when we're talking about the healthcare sector, we mean everybody, and in no way are we leaving out the commercial payers. One of the things that Kirsten talked about in her presentation and talking about the identification of and addressing of social needs is that it can happen to anybody. Your payer status does not absolve you or does not protect you necessarily from having a social needs event or social needs in some part of your life. And so the idea here is to develop a system wherein we're able to respond to that as they arise in someone's life and as they occur based on their social situation, social setting. And so for a system to be truly responsive, we do not wish to leave out any particular health part of the healthcare sector.
You describe workforce challenges and mention social workers several times. Who else do you envision as sitting in the health system or with community partners to actualize your recommendations? For example, patient navigators or community health workers?
Exactly those two, patient navigators, community health workers. We talked a lot about gerontologists who are throughout the Aging Network. We did spend a lot of time on medical legal partnerships. We also mentioned nurses, physicians, assistants. We tried to not forget anyone. Anybody I'm missing that we can add to?
Public health and
Public health.
data technology.
How could I forget that? Public
But I
health
think
and
we
data
also
technology.
acknowledged we because our charge was to focus on integrating social care into the delivery of health care. But I think an important point that Chris made was we also acknowledged that there is this broad group of personal caregivers, of family members, of really others who are really part of the social context, and to figure out they are people who are
no
working
more than most people do. Yeah.
Exactly, and one of the things that we that in the ideal world we figure out these pathways for communications should include obviously formalizing relationships between organizations, but also ways to enhance communication pathways with these more informal caregivers who end up being really critical for
that
health
they're part of
outcomes
the
for
team
patients.
as well, particularly if we look at some of the best practices around multidisciplinary rounds. Ideally, it would be within the hospital context, but also bridging out to the community-based organization and who indeed is coming in and out of a person's home to be part of that team.
Next question is to support research and evaluation at the level needed to change policy. External funding sources are needed. What federal sources and non-federal sources are currently allocating priorities to integrating social care?
Thank you so much for that question. This is Karen DeSalvo, and I think that you will find in the report that throughout the chapters we say that there's strong evidence it needs to be strengthened, and the evidence strengthening needs to happen not only in some of the more traditional approaches that we take to building science, say a randomized controlled trial, but some of the newer methodologies like implementation or embedded science, and that calls out, therefore, that in the federal government, the NIH has a role to play, the National Institutes of Health, but so do other parts of government that fund science, like the Agency for Healthcare Research and Quality or the Center for Disease Control. And we also mention in the report that PCORI, because of its field work and because of its very patient-centered focus as well, is an opportunity to do implementation and embedded science on the front lines. The other place I would mention in the federal government that has already been engaged in some of this work is the Veterans Administration, which has a portfolio that supports linking, particularly through primary care, veterans with social care needs and some health services research in that space. But a particular call out for this is that in addition to there needing to be funding from federal sources and the private sector, whether that's from philanthropy or health plans, we call for there to be more funding of science and conducting of science. There's an opportunity that we saw for partnering with academic institutions and healthcare systems or health plans that are engaged in work to integrate social care into healthcare. So taking advantage of innovations that are already happening in the field, but shaping those in a way that the findings can be reportable in the peer-reviewed literature, and they're therefore more likely to share lessons learned in a very transparent way, and where appropriate, spread and scale those good lessons. There seems to be more need to take some of these innovations and put some scientific structure around them and report them out in the peer-reviewed literature so that more folks can learn from what's working and what's not working.
And it's Robin Golden, just to call out private foundations. Many supported this report, and hope that they will stay with us in terms of disseminating, get the words out, because it could not have happened without them. So let's not forget private foundations who are critical in this area.
This is Chris Esguerra. To underline the second part of what Karen is saying is for those that are really on the delivery side, social services, organizations, providers, as you're doing this, is to also keep in mind to be thinking about the innovation work that you're doing and think about the evaluation and dissemination of the results. I'm often prone to saying that we're really good at doing. We're sometimes not that great at actually evaluating what we're doing. And the call to action here is to be mindful of, as you're doing these innovations, think about who can you partner with to begin to think for the evaluation piece and to disseminate.
We have a question from a social worker at a university's Comprehensive Cancer Center who says, we are trying to start and push for a larger discussion at our institution about better integration of social care. How would you recommend that we kickstart this discussion, as we often just have an audience within our own teams?
Wonderful question. I'm sure you're doing incredible work trying to attempt what you're doing, and it is hard to get it beyond the teams, but I mean, taking a report like this and showing it to the different stakeholders in your institution could be very useful in helping them join the path with you. So please consider talking about the 5 A's and talking about different components of this. I think it could help push it along. Sometimes we're not always heard in our own institutions, but having something from outside that's just been announced today could be a catalyst for moving on with more of a social care agenda.
Yeah, this is Kirsten. I also agree with that. And now, speaking as a physician, I think one of the frameworks that comes out in the very first chapter of this report is the reason that that healthcare is having these discussions and is at the table to think about it is because we are not getting the outcomes that we anticipate from healthcare. We're investing a lot of money in healthcare, and oftentimes the outcomes fall short of what we might expect. And given the importance that social factors play on those outcomes, that is part of the reason why the sponsors for this report, this committee, came together to do this type of work. And so I would urge you to consider both the work in this report, the fact that it's come out, the high level of interest from many sectors around the country, but also really grounded in the fact that healthcare is not achieving the outcomes it needs to achieve, and that addressing social needs is going to be critical to doing that.
Next question is, with the solidification of data locked up in proprietary electronic health records, what are the specific recommendations for encouraging cross-sector communication between healthcare providers and community-based organizations?
This is Karen DeSalvo. Thank you for that question. The journey on unlocking this data in the electronic health record is a story of allowing it to be siloed and for allowing data blocking to happen, which caused Congress to have to step in 21st Century Cures and make that against the law. So it's very important for the audience to know that though data has been locked in systems, the law and the regulatory space, the regulations that are coming from the administration seek to unlock that healthcare information. I think on the good, the social care platforms have been working to develop their systems using a technology, the application programming interfaces, these APIs, doorways to the data that are open and not proprietary in the way that the electronic health records were built. So we're already starting in the social care space from a better foundation, though there is a pathway that could lead to a lot of siloed block data, and we are encouraging that to not happen in the report through the creation of shared open standards driven by support not only from the federal government but the private sector to take on their own action. And there's already been some interest and enthusiasm in this space, building upon the success that's been had with technology like FHIR, for the technology folks on the phone that will resonate with you, that we've learned that there is a better, smarter, faster, cheaper way that we can build technology that's interoperable using modern technology. And that's the direction that the social care platforms are already going, and that we were encouraged in this report and recommend some specific pathways. And just one final comment about this, though, is one of the other lessons we learned about healthcare data is that it should be controlled by the consumer. And we were probably not as upfront in building it with them at the center, and that is the way we should be building these longitudinal health records that include social care for individuals, to make sure that they have access to their information, that they can read and change things that might be wrong, and that they're a part of the communication that's digitally enabled. It's not just between the community-based organizations and the healthcare organizations.
Thank you. Next question is, addressing the social determinants of health is clearly the right thing to do, but the investment requirements are not clear for health systems. Did anything come up in the research or recommendations about how health organizations should fund the infrastructure investments while best operational practices are still being determined?
This is Chris Esguerra. So yes, in the report, we take that into careful consideration. A way to think about it are the areas of, first, expanding the definition and being able to fund as overall healthcare the actual social needs care or social services that are occurring to support individuals. That gets to this idea of sustainability of future models and how to do that, as well as moving to value-based payment models. In addition, we acknowledge that for social service organizations or community-based organizations, that the administrative capacity is in no way similar to what is the administrative capacity in the healthcare sector. And therefore, there's the role for governmental, private, philanthropic organizations to fund the capacity building for these organizations in partnership to develop and grow this particular area.
It's Robin Golden. We also have found in my institution that if we can show some wins, for example, in the housing arena, setting aside 6 apartments with wraparound services for our patients has shown remarkable results in terms of what the healthcare institutions sometimes, quote unquote, bottom line is in terms of readmissions, unnecessary ED visits, unnecessary admissions, period. So those kinds of metrics that you put around these resources developed in a very simple level can show that return on investment that your institution may be looking for.
Thank you. We have time for one last question. How can these goals be met through developing partnerships between community-based organizations and healthcare system? Any thoughts on how to move hospital systems toward real partnership?
Well, thank you for having the last question be about partnership, because that is such a big, this is Karen DeSalvo, that's such a big theme in this report. Medicine should do this, but not do it alone. And we make some recommendations for a few strategies that would help move healthcare systems. One is to move more towards value-based care and models that include downside financial risk. That changes the financial incentive and allowances for hospitals to be more engaged. We make recommendations about hospitals taking advantage of their community health needs assessments to use that is an opportunity to do those in partnership with public health, in partnership with community-based organizations to generate what's necessary for change in community, and then to take action by if they're going to make investments to fill in gaps identified in those health assessments. And even if you're not required by the IRS as a hospital to do those, it's still very important and appropriate to do it. And we actually make a recommendation in the report about how states might leverage some of their authorities in oversight and regulation to encourage all healthcare systems in their states to work in partnership with others to develop community health needs assessments and then act upon those in concert with others. So those are a couple of examples, I believe, that we have more.
It's Robin Golden, and I just want to say to hospitals, when their community-based organizations around them seem different than they are, but we need to respect those differences. And when they come knocking on your door as hospitals, to let them in the door. Because lots of times that doesn't happen.
And this is Chris Esguerra. And while the question is bounded to hospitals, I think it's good to keep in mind to bound it to the entire healthcare sector. And this idea ultimately of partnerships also means an attention to the power dynamics of how is it that we attend to and understand each other in developing these partnerships and understanding each other's capabilities and how we can leverage each other's capabilities. So this speaks easily to hospitals, but also can speak to health plans and other types of providers and systems in terms of how is it that we go out and look to see who can partner. Conversely, as community-based organizations, you yourselves are seeing the needs out there, and definitely, as Robin has said, it's very appropriate to approach the various systems that are in your particular area to be thinking about how best to partner. And again, while we talk about health equity from the individual perspective, we're also talking about equity in partnership and equity in developing these things and really pushing through innovation.
So thank you very much. We're at the top of the hour, and we really appreciate both the great amount of interest in this release of this report, as well as the really outstanding questions. I think you can hear from the answers to the questions that the report attempts to address a pretty broad scope here, but with very specific attention to many of the themes that come with the questions. And I would really encourage all of you to read the report as well as to use it to continue to further the types of activities and, most importantly, the discussions around this important topic. Thank you very much.
Thank you, and thanks to those who submitted questions. We had just shy of 2,000 people join us today, and the questions still keep rolling in, so I apologize if we did not get to yours. Once you exit this webinar, you will be redirected to our report page where you can read the report and all the materials that come with it. I'd like to thank our speakers once again, and thanks to all of you on the line who joined us this morning.